Good morning, C3. Can you hear us? Can you see us?
Good morning.
Morning, Dr. Raj. How are you?
I am fine. I'm just here briefly to welcome you to C3. You look great.
My pleasure.
Chandigarh, I'm sure the weather is wonderful.
Weather is
and
wonderful.
I'm glad that we were able to resolve the satellite issue.
That's right.
So I'm going to turn over to the fantastic group of panel and the moderators.
So good morning everyone over there, and thanks Raj for the invitation to do the live from Chandigarh. Let me introduce my team. My right side, Dr. Ankush, my fellow is there. Dr. Prasant, assistant professor from the department, my department. Dr. Vikas is there. Then we do have the team of my nursing staff, technician. Deepak is there on the IVAS. And Dr. Prasant is going to tell about the case. Dr. Prasant, please.
Good morning to all. We are presenting a case of a 60-year-old female, 60-year-old non-diabetic, normotensive, non-smoker female who got admitted with rest angina of 2 days duration on 17 June this year. The clinical examination was unremarkable. CKMB was within normal limits. Biomarkers were negative. ECG showed ST elevation in the lead AVR with significant ST depression in inferior and anterior leads, suggestive of left main disease. Echocardiography, it showed ejection fraction of 50% with mild MR and no significant regional valve motion abnormality. The patient was taken for coronary angiogram, which showed significant disease in the shaft of left main, and there was mild plucking in the mid LAD, while rest of the left system and right system was normal. These are the various views showing the left main disease. And this is the right artery. So this is a case of isolated left main shaft disease with a good LV function, and our plan is to do PCI to left main.
So we have done the check angiogram today itself. Can you show the check angiogram? So can you see it, AP caudal view? So this is the shaft disease of the, hello. So can you hear us? Can you see us?
Yes, we can hear you and we can see you.
Yeah, fine. So this is the AP caudal, which is showing the tight distal left main disease. Next view, please. Areocranial, again, and this is the spider view. There is some ectatic segment in the proximal and ostial LAD. Left circumflex ostium seems to be okay, and then patient is hemodynamically stable. Blood pressure is 154. Heart rate is okay. We have put a 7F femoral sheath and then planning to go ahead with the 7F guide JL 3.5 7F.
So how certain are you that osteal circumference is okay? At least from here, it looks as though the very osteal portion may be compromised.
Yeah, you are right. So it's not so clear about. We are planning to go ahead and do the IVAS after crossing the lesion. So that's going to clarify about the involvement of the ostium of the left circumflex as well.
Perfect.
Can you tell us a little bit about the anticoagulation and antiplatelet regimen that you?
Patient is already on the aspirin and clopidogrel from last 10 days, and she is also on the low molecular weight heparin during the hospital stay. AP caudal.
Is that a common practice that you do a heart catheterization and then you open a left main 10 days later?
Sorry? No, it's not. We have kept this case
Well,
for
you
the.
just mentioned that the patient. Go ahead.
Don't use 2B3A inhibitor for this patient.
Apparently, there doesn't seems to be any thrombus that, but let us see the IVAS finding, and then we can decide about the GP2B3 inhibitor as well. Test, please. No. AP caudal.
Caudal.
Test, please. Next wire. So now we are across the left circumflex. स्पंज लगा दें, स्पंज between the two. Top.
Can I just ask what wire and guide you're using?
Sorry, it's a guide 7F guide.
Which guide catheter?
It's a JL. JL. Test please. Okay, fine. Epicranial.
So you're protecting the LAD, you're querying both arteries, you want to make sure that you are protected in case something happens?
So we are planning to put two wire, one across the LAD and another across the LCX. This wire seems to be short long.
So is your intention to do an IBUS now, or your intention is maybe to open up this
Open up
left main
open
stenosis
up the left
first
main
in
stenosis
some way and then
first.
do the IBUS after?
That's right, that's right. The plan is to have a dilatation of the left main first and then to do the IVUS. Because the left main is very tight and then it's likely that we are going to hamper the blood flow across. So we are across the left main, epicaudal.
Some slope in the LAD.
Balloon 2.5. So now we are planning to dilate it with a 2.5 millimeter balloon.
And which wire are you going over with the balloon? Is that the one in the circumflex or the LAD?
It's LAD. Test please. Test please. Inflate. 12. Negative.
Is your bifurcation involved or not?
I am not sure.
All right. We all feel better now.
IVUS. So we are planning to go ahead for the IVUS study now.
While that's being set up, just a question for the panel. Would anyone use, the EF is normal, but it's a left main, it's shaft, it's not distal. Would anyone on the panel use mechanical support for this case?
I don't think so. I certainly wouldn't. I'd have it in the room, but the likelihood of it's just going to be short inflations, even when the stent's inflated, so it's unlikely.
Yeah, the ejection fraction was okay.
I wouldn't either, although I'd probably have a 4 French catheter in the left, in the contralateral groin, just in case.
So here we are across the LAD. Can you show the IVUS image?
No, we don't have the IBUS images we could have. There we go.
You can see the diameter of distal mid LED is around 2.5 millimeter, and there is eccentric plaque in the mid LED. And some degree of calcification is also there in the mid LED. And the diameter of LED is around 3 mm. Yeah, this is the point showing LED and LCX bifurcation. This is the tightest point in the left main.
This is the point where the tightest.
Yeah, this is the tightest point, which is having some degree of calcification. And minimal diameter is around
Yeah, but minimal, eh?
yeah, 3, 4. The diameter of left main is around 4.5 to 5 millimeter. This is the ostium of the left main, which is clean without any plaque.
So any comment how to go ahead now? What about the LCX ostium, Deepak?
So it is okay, sir.
And what's the size of the?
So is the plan now to repeat that into the circumflex?
Are you planning to put the IVUS into the circumflex?
No, as the ostium on the left circumflex seems to be okay, we are not planning to put, and now the plan is to go ahead and put the stent from left main to the LAD, maybe ostium of the LAD. So what's the size of ostium of the LAD?
So we'll do a professional stenting, left main LED.
Yeah, that's right. What's the ostial LED
So
size?
you are comfortable with the visualization of the ostium of the circumflex from the LAD. This is what you're saying.
Yes. Or maybe we can have a left
The panel was asking.
spider view to look for the ostium of the left circumflex.
We all thought that you are going to do an IVUS of the circumflex, which was the one that we were more concerned.
Okay,
we were
no
not
problem.
concerned about the LAD. Actually, we thought that the LAD was fairly normal. We do believe also that the circumflex is fine, but it's the one that has disease appears to be more the circumflex than the LAD.
Fine, fine. Let us go ahead for the left circumflex IVUS.
The ostium looks clean, but there may be something there in your view.
So here we are across the left circumflex. Go ahead.
Yes.
The vessel size of LCX is around 3 mm, and there is eccentric plaque in the proximal LCX.
So let's see the IVUS. We need the IVUS.
Yeah. And this is
We can't see that image here.
Can you see the IVUS image?
and
No.
this is again we are in the left
There it
main.
is.
AP quarter. So this is the left main IVUS.
Can you just replay the IVUS?
All right, I'm sure that you saw the circumflex. We have not seen the circumflex,
Yeah.
but we.
Sir,
we
can
take
you
your
run
word.
the
It
circumflex
was-
run
it was
again?
fine. Okay, perfect.
This is the replay of the LCX IVUS, which is showing a vessel diameter of around 3 mm in the proximal part with eccentric plaque. Can you run? And this is the point of LCX and LED bifurcation. And now again we are in the left main.
So IVUS study doesn't show a significant stenosis of the ostium of the left circumflex. So what does panel feel like? Should I go ahead for say left main to LED stenting? Last in what?
I think you can stent to the left main LED and then you can see what about the
Yeah, fine.
later.
So
So can you show us the IVUS of the distal left main then?
distal left main, it's a tight stenosis.
Can
If you
show us
see
the
this
tail-
this angiogram, the bifurcation point is very tight. So left main to LED IVUS. So here we are. See, here is a very tight stenosis. So it's a next I think 3.523.
Yeah, so the question is going to be whether you have a landing zone in the left main or whether you've got to go into the LID and hope that the
I
strokes
think
will
we
be
have to
okay.
go to the LED, so there is no sufficient landing zone for say bifurcation site. So it's going to be say crossover from left main to LED, 3.523
3.523.
Alpine.
Which stent that you will take?
So we are planning to put a 3.523 from left main to LED and then going to do the port thereafter. Is it okay?
Sounds like a plan.
Sure.
LED.
So what is the panel approach here? Does everybody will end up with a kissing balloon at the end? We'll look at the result. We'll try to avoid kissing balloon at the end.
Personally, I wouldn't do kissing balloon because it potentially destroys the architecture of the stent. So unless the circumflex is
Test, please.
compromised, I wouldn't. And if it was compromised, I would convert this into a culotte.
Test please.
I would do the same.
Stop. Negative. Inflate. 6. 8. 10. 12. Negative. Hmm, 15. Negative.
Did you come from the ostium of the left main?
So we have dilated this 3.5 millimeter balloon at
So that-
15 atmosphere. Is stent been deployed from say left main to
So
LED?
I think I have to make this comment for the audience. You did make approximately a 0.5 second inflation both times. There is a lot of not data on the follow-up, but there is data that it should be a longer inflation. Than
You
just
are
a
right,
few
but then we are
seconds.
going to do
Some
say
people consider
pot.
it has to be at least 20.
See, with the left main such a tight lesion, I thought let me have a brief inflation, and of course we are going to do the pot as well, so that will take care of the educator position. LCS ostium seems to be okay angiographically. Let me do the pot in the left main and then decide about. So a 4 millimeter balloon and then 4.5.
4.8. 8.
bar.
So angiographically, maybe you see better from there. Angiographically, it doesn't look to me, at least, that you went all the way across the circumflex. Do you have a stent across the circumflex into
Yes,
the LAD or not?
It's across the circumflex, right?
There was quite an elegant paper in Eurointervention within the last year looking at balloon inflation times and stent expansion, and it showed, from my recollection, 30 to 45 seconds as a minimum to equilibrate the pressures and get maximum expansion. But I can take their point of doing very short inflations just for deploying the stent, provided they're going to post-dilate, which they are.
Test please. Inflate.
Would you take your circumflex wire off, or
No,
you
it's
want to
there in
leave it there?
C2. 12. 15.
15.
Okay,
What size balloon do you have in there now?
it's a 4 millimeter balloon. Good. 15
I'm at 15.
and negative. So this is after 4 millimeter balloon dilatation. It's a spider view. So seems to be okay. Let me dilate the proximal left main with
We'll do
4.5
IVUS for
millimeter
the
balloon.
kick.
So I was,
You will do IVUS for the
or
ultimate kick?
should I go ahead with 4.5 and then do the IVUS? It's a 4.5 millimeter balloon.
Yes.
Because if you see the left main size was 4.5, so
I'd balloon it first.
Yeah, I think you have to balloon it first, yes.
Yeah, do what you think. I would do it. You think you need to optimize it first, and then once you think you're optimized, interrogate it with IVUS.
I think that's the beauty of doing a pre-IVUS. Some people only want to do the post-IVUS, make sure they have good deployment, but it really gives you that confidence to go bigger with your stent up front instead of not feeling comfortable to go 4 or 5, for example.
test please. So go ahead. So now it's a 4.5 millimeter balloon. 12, 15, negative. Go ahead, 15. Negative. Fifteen and negative. 15 and negative. Forgot this one. Just hold on. So this is following the 4.5 millimeter balloon dilatation. IVUS. So let me have a look on the IVUS.
Angiographically, that looks fantastic from here, and it really begs the question, who needs bypass surgery?
AP quadrant. Center only. Okay, let's go ahead. So this is the IOS run from left LED to left main.
This is the bifurcation point. Now we are in the stented area. The minimal lumen diameter is 4 mm, and it looks well opposed.
So it's a well opposed stent. My catheter is at the ostium of the left main, and it's a well opposed stent across the left main to the LED. Okay. Okay, fine. Just stop. So, any comment about the ostium of the left circumflex?
I would leave it alone.
Left circumflex ostium seems to be okay, and the stent is extending into the LED as well. Patient is hemodynamically stable.
So it looks like the stent ends just at the very distal left main.
And
Can you repeat that, please?
this is the result. LCS seems to be okay. LED is flowing well. Any comment?
Do you think that we need to dilate the distal left main with the ostium of the LED?
I think there's no stent in the LED, but I think the distal left main, there's still a gap. I think I will probably go ahead and just balloon it probably distally a little bit.
But then, so IVAS has shown a well opposed stent across the ostium of the LED. Can you again have a look on? Is the ostial LED stent is fine?
Yeah. Why don't you play that IVAS run for us again, please?
Can you
repeat
run the
the
IVAS
IVAS
again? So this is the run from LED to left main. So
This is the bifurcation point. And now we are in the left main. The stent is well opposed in the distal part of the left main.
So what do you feel? Should I dilate it with the say 3.5 millimeter balloon?
There's one short piece there between 12 and 3 o'clock where there looks like there's some either protrusion of tissue or thrombosis within the stent.
Okay. So do you feel should I dilate it with 3.5 or 4 millimeter distal end of the stent?
Well, it looks like there's a portion that's only 2.5 millimeters by 2.5 millimeters. So, if it were me, I would take it up to 4 millimeters.
Agree.
So the size of the LED is not small.
Size of LED is 3 point. What's the size of the LED? 3.5. So let me get the 3.5 millimeter balloon.
You pre-dilated the LED before. Are you thinking of putting a stent or no?
No. I am not planning to go ahead for the C. Only thing is the distal end of the stent from left main to LED, that part has to be dilated with 3.5 millimeter. Rest of the left main stent I have already dilated with 4 followed by 4.5 millimeter balloon, and it seems to be well opposed on the IVUS study. So the distal most part of the stent seems to be somewhat under expanded. So let me dilate it and then have a check angiogram. Double mic, please. Just hold on. So I think here we are at the distal end. Let me have a look. Here we are at the distal end. Go ahead. 15. 17. Negative. Single mic, please. MTG. So this is the result after balloon dilatation. Seems to be good. Any comment?
Angiographically, it looks fantastic. I'd probably favour doing one more IVUS run just to be absolutely certain.
You have 4 minutes.
Yes, you have 4 minutes of transmission time, so
Okay.
perfect for an IVUS.
Do you want me to repeat the IVUS across left main to LED? I think it's okay. We are
Yeah,
dilated with.
we'd like to see that distal.
Do you want to have a look on? So let's have the IVUS across left main to LED now. So IVUS run. So it's a mid LED.
Is it possible to put that on the main screen for us?
Can you put on the
Main
main
screen.
This is the point of bifurcation, and now we are in the distal edge of the stent, and it is well opposed and well dilated. The stent is well opposed and well dilated.
I think this is a satisfactory result across the left main to LED stenting. L6 ostium is fine and good flow across both the LED and left circumflex.
There's still something in the middle of the stent that you again see between 12 and 3 o'clock, just very transiently, and it's difficult to tell whether that's tissue
Let's have a
protrusion or
Yeah,
thrombus.
there's a mild prolapse, tissue prolapse around 12 o'clock or 3 o'clock. there's a plaque prolapse.
As there is no thrombosis, I don't feel like there is need to go ahead for say any GP2B3 inhibitors. Any comment from the panel to start with GP2B3 inhibitor in this particular patient?
I don't think so. I think you've got very nice.
It's a
flow
nice
to that
result.
stent. Angiographically, we don't see much.
It's just there. There, you see it?
You know, look, if there's any question, just after you're done with the transmission, watch it for a few minutes and see if anything becomes visual. Okay. Well, listen, we're out of time, so congratulations on this.
Okay.
We think you have a very nice looking result.
Thanks for the attention.
Thank
Thank
you.
you.